Welcome. In this second session on prechiasmal lesions, we will be discussing ischemic optic neuropathies, compressive optic neuropathies, and infiltrative optic neuropathies. Starting with ischemic and other vascular optic neuropathies, ischemic optic neuropathy is the most common acute optic neuropathy after the middle age, and it can be classified as anterior and posterior according to the portion of the optic nerve it involves. The anterior ischemic optic neuropathy can be arteritic or non-arteritic. Majority of AION is non-arteritic. Only 5 to 10% of AION is arteritic. So AION presents with sudden onset painless monocular vision loss. So the loss in vision is unilateral without pain and occurs suddenly. There is an RAPD in the involved eye, and visual field defects is usually altitudinal but may be of any pattern. So this is an altitudinal field defect involving the inferior hemifield. Arteritic AION is caused by vasculitic occlusion of short posterior ciliary arteries in giant cell arteritis. The mean age of presentation is 70 years. The acute loss in vision may be preceded by episodes of transient loss of vision and diplopia, but these transient events are very uncommon with non-arteritic ischemic optic neuropathy. Associated symptoms in giant cell arteritis include headache, scalp tenderness, important to remember, jaw claudication, also important to remember, malaise, anorexia, fever and weight loss. However, 25% of patients may not have any associated symptoms called occult GCA. Signs in arteritic ischemic optic neuropathy include severe visual loss less than 6/60 in the majority of the patients, and may even be no light perception, and the severe visual loss develops over hours to days. There is RAPD. The disc edema is characteristically described as chalky white. There can be cotton wool spots which can be present away from the ONH in the peripapillary area. Disc at risk sign is not present in arteritic AION, and this disc at risk sign is very important in non-arteritic AION. Choroidal ischemia can occur and cause peripapillary subretinal edema and pallor. There is thickening of temporal artery with nodularity and reduced pulsation. In fluorescent angiography, we find delayed optic nerve head and choroidal filling. So both the optic nerve head and the choroid shows delayed filling with fluorescent angiography. ESR and CRP are raised, but they may be normal initially at presentation, and there are significant false positive and false negative results with these tests in arteritic AION. Platelet count is usually elevated, and the visual loss in the affected eye rarely improves. The primary goal of management is to protect the vision of the other eye and not to revive the vision in the affected eye, because the vision loss in the affected eye is rarely recoverable, and to also prevent other systemic vascular complications. Untreated, the fellow eye is involved in the predominant majority of patients, 95% in 2 weeks, and these patients then thus become functionally blind. With treatment, however, this risk drops to 13%. So whenever we suspect AION, we should immediately start therapy with intravenous methylprednisolone, 1 gram per day for 3 to 5 days, and this should be followed by oral corticosteroids. The oral steroid therapy should be tapered very slowly over 1 year or more, and this tapering should be monitored by repeated measurement of ESR and CRP. So during the tapering period, if the ESR and CRP is found to be rising, then the steroid therapy should also be increased in dosage. Tocilizumab, an anti-IL-6 receptor antibody, has been found to be effective as an adjuvant therapy during steroid taper, thus reducing the total cumulative dose of steroids required in the tapering period. Oral aspirin may also be initiated. Temporal artery biopsy confirms the diagnosis, but it must never delay the initiation of steroid therapy, which is absolutely urgent. Temporal artery biopsy can be delayed for 1 to 2 weeks without compromising the results of the biopsy, and the biopsy can have false negative results because of discontinuous involvement of the temporal artery called skip lesions, or the temporal artery contralateral to the involved eye may be involved. Non-arteritic AIUN occurs due to vascular insufficiency secondary to structural crowding in a disc at risk. A disc at risk is a disc which is characterized by a small size with a virtually absent physiological cup. The ischemic changes have been found to be localized within the scleral canal in post-mortem examination. The mean age of occurrence is 60 years, slightly less than arteritic AIUN. Predisposing factors for NAIUN is a disc at risk, the most important predisposing factor. Then we have systemic hypertension, diabetes mellitus, hyperlipidemia, the vasculopathic risk factors, coronary artery bypass grafting surgery, obstructive sleep apnea disorders, and hypercoagulable disorders. Other risk factors which are suspected to cause non-arteritic AIUN are optic disc drusen, smoking, anemia, chronic renal failure, migraine, phosphodiesterase 5 inhibitors, nocturnal hypotension, amiodarone, interferon alpha, and cataract surgery. So non-arteritic AIUN presents as a sudden onset of moderate visual loss, and this happens usually upon awakening from sleep. The visual acuity in majority of the patients is better than 6/60 in contrast to arteritic AIUN. This visual loss is most commonly sudden and without further deterioration. However, some patients have further progressive loss of vision, which may be episodic or a steady decline for a few days to weeks before it stabilizes. Recurrent episodes after 2 months in the same eye are very unusual in non-arteritic ischemic optic neuropathy. RAPD is found, and the optic disc initially shows hyperemic edema, which may be segmental or diffuse. So this picture shows a diffuse hyperemic optic disc edema. So hyperemic edema is in contrast to the chalky white disc edema which we find in giant cell arteritis at presentation. So in non-arteritic ischemic optic neuropathy, the hyperemic edema which happens at presentation is followed by optic disc atrophy within 6 to 8 weeks. So these three images are sequential fundus photographs of the same eye. The first one shows the appearance of the disc before the onset of the non-arteritic ischemic optic neuropathy, and we see a disc at risk with virtually no physiologic cupping causing structural crowding of the nerve fibers within the disc. The second image shows the appearance of the disc, the hyperemic edema at the onset of NAION, and the last image shows optic atrophy developing later on. Peripapillary flame-shaped hemorrhages and arteriolar narrowing may also be present. Non-arteritic ischemic optic neuropathy does not have any other new systemic symptoms at the onset of the disease or immediately preceding. The contralateral eye shows a disc at risk, and in the affected eye, this disc at risk sign may be difficult to appreciate. So we have to check the contralateral eye to find a virtually absent physiological cup. The visual field usually shows an altitudinal defect, but any pattern is possible, and the patterns do not correlate with the clinically involved sector of the disc. FFA shows delayed filling of the optic nerve head. The choroidal filling is normal in non-arteritic ischemic optic neuropathy. Risk of fellow eye involvement is much less than in arteritic AION, 15% in 5 years, and this leads to pseudo-Foster-Kennedy syndrome, with the initially involved disc showing atrophy and the newly involved disc showing hyperemic edema, whereas a true Foster-Kennedy syndrome occurs due to an intracranial space-occupying lesion, which causes atrophy of one disc due to compression and edema of the other disc due to raised intracranial pressure. In non-arteritic AION, almost 1/3 of involved eyes show some improvement with time. Treatment of non-arteritic AION include treatment of systemic risk factors. However, steroids have no role in treatment, and IONDT trial showed optic nerve sheath fenestration has no benefit and can actually be harmful. Posterior ischemic optic neuropathy is ischemia of the retrobulbar portion of the optic nerve, and it is characterized by sudden onset severe visual loss with RAPD and visual field loss, as well as an initially normal appearing disc because the involved segment of the nerve is away from the disc. The disc, however, later becomes atrophic. It is a diagnosis of exclusion and it occurs in three scenarios. Arteritic involvement can happen in GCA, a non-arteritic can happen with risk factors and clinical codes similar to non-arteritic AION, or it can be perioperative. Perioperative is the most common cause of PION, and this occurs due to systemic hypotension. It is usually associated with prolonged spinal surgery in prone position, but can also occur after gastrointestinal bleed and trauma. In perioperative PION, the vision loss is usually sudden, severe and bilateral immediately after the surgery and with little or no recovery. Coming to the other vascular disorders of the optic nerve, diabetic papillopathy is considered to be a mild form of non-arteritic ischemic optic neuropathy and is usually unilateral. It is often associated with a rapid drop of HbA1c from very high levels. The patient may be asymptomatic or only mildly symptomatic. However, visual acuity, visual fields and pupil reactions are usually normal. Optic disc shows hyperemic edema with surface telangiectasia, that is dilatation of the microvasculature on the surface of the optic disc, and these telangiectatic blood vessels on the surface of the disc do not leak on FA. These vessels are generally oriented in a radial distribution and do not leak, in contrast to neovascularization of the disc, which is found in proliferative diabetic retinopathy. The contralateral eye usually shows a disc at risk, and associated diabetic retinopathy may or may not be present. Most patients recover with resolution of disc changes over several months. Rarely, diabetic papillopathy may progress to full-blown non-arteritic AION. Papillophlebitis is another vascular disorder of optic nerve and is considered to be a mild form of central retinal venous occlusion. Here the patient presents with mild visual difficulties and or transient visual obscuration events. Like diabetic papillopathy, visual acuity, color vision and pupils are usually normal. Disc shows significant hyperemic edema with marked retinal venous dilatation and engorgement with or without retinal hemorrhages, which are limited up to the equator. Visual field examination shows an enlarged blind spot. FFA shows venous staining and leakage without retinal ischemia. Hypercoagulable disorders need to be ruled out in such a situation, particularly in young patients. So we have an important differential here: disc edema with mild or no visual symptoms, and we have papilledema. We have asymptomatic disc edema, which may progress to non-arteritic ischemic optic neuropathy. We have diabetic papillopathy and papillophlebitis, as we have just seen. Hypertensive retinopathy may also have disc edema with mild or no visual symptoms. Coming to compressive optic neuropathies, prechiasmal compressive lesions occur due to intraorbital and intracanalicular space occupying lesions. The symptoms and signs of compressive optic neuropathy include a slowly progressive monoocular vision loss. So compressive optic neuropathy have a slowly progressive course over weeks to months. There will be RAPD and visual field loss, and if the optic nerve completion is far away from the optic nerve head, the ONH is initially normal and later atrophy develops. However, if you have an anterior orbital lesion, it may cause optic nerve head edema and or chorioretinal folds. The anterior orbital lesions also cause more proptosis than compression of the optic nerve. Opticociliary shunt vessels are also found, as we have discussed in papilledema and associated proptosis. Ophthalmoplegia and lead signs are also found as part of a orbital process. The most common causes of optic nerve compression are optic nerve sheath and intracranial meningiomas and optic pathway gliomas. Lesions extrinsic to optic nerve such as the orbital tumors may also cause compressive optic neuropathy. However, we will not be considering them here and defer their discussion to orbit as a broad topic. However, among the orbital tumor, the most common one is cavernous hemangioma, and it rarely causes optic nerve compression. Workup of orbital tumors include MRI with contrast and fat suppression or a thin slice CT with contrast. CT scan has the added advantage of revealing calcification and bony abnormalities. Meningiomas arise from proliferation of meningoepithelial cells of arachnoid. An arachnoid being a part of the meninges, meningiomas are extrinsic to the nerve substance. Compressive optic neuropathy can be caused by meningiomas arising from two locations, most commonly by meningiomas from the sphenoid bone and much less commonly by meningiomas arising from the optic nerve sheath. Meningiomas arising from the sphenoid bone arise from the sphenoid wing or the tuberculum celli, and when they have an orbital extension, they cause optic nerve compression. However, they can be surgically resected without damaging the optic nerve. Optic nerve sheath meningioma occur in the intraorbital or intracanalicular region, and they cannot be surgically resected without damaging the optic nerve, thus causing loss of vision. And meningiomas are the second most common primary optic nerve tumor after gliomas, and they are usually unilateral. Meningiomas usually occur in middle-aged women and may be present with the classic triad of painless, slowly progressive monocular vision loss. Some patients have transient visual loss when they look towards one side, called gaze-evoked transient visual loss, because of compression of the nerve by the tumor and in a particular direction of eye movement. They also have slowly developing optic atrophy, and they also have opticociliary shunt vessels. As we have seen, opticociliary shunt vessels can happen with any cause of chronic central retinal venous obstruction. Imaging of the optic nerve sheath meningioma shows a diffuse tubular enlargement of the optic nerve with expansion towards the orbital apex. Tram track sign is seen in axial scan. So this is an axial scan showing the tram track sign, and a corresponding ring sign is seen in coronal scan. And these are due to contrast enhancement of the involved and thickened optic nerve sheath surrounding the non-enhancing optic nerve substance. Optic nerve sheath meningiomas also show calcification of the nerve sheath, and it may also show fine extradural extensions. Sphenoid wing meningiomas show adjacent bony hyperostosis. This image shows a sphenoid wing meningioma arising from the sphenoid wing with bony hyperostosis of the sphenoid wing. So how do we manage optic nerve sheath meningiomas? Optic nerve sheath meningiomas may remain stable or show very slow progression. This is their characteristic. They show very slow progression, except in children who may show rapid expansion of the tumor. However, meningiomas happen less commonly in children. It is responsive to radiation therapy, and radiation therapy is indicated in progressive vision loss. Focused radiation treatment with stereotactic fractionated radiotherapy limits damage to surrounding tissues. Surgery causes damage to the vascular supply of the optic nerve and is not usually performed. Indications for surgery include unilateral tumor showing tendency to extend intracranially or contralaterally, or a blind, disfigured proptotic eye. So meningiomas commonly show slowly progressive visual loss, and survival is excellent with mortality near zero. Optic pathway gliomas or OPGs are the most common primary tumor of the optic nerve. They arise from neuroglia, usually astrocytes, but also occasionally oligodendrocytes, and neuroglia reside within the nerve substance. So OPGs are intrinsic to the nerve substance, in contrast to meningiomas, which are extrinsic to the nerve substance. OPG is usually present in an younger age group, the first 2 decades of life usually, in contrast to meningiomas which present in the middle age. OPGs can affect the optic nerve or the chiasm or both. OPGs involving the optic nerve presents with orbital signs of proptosis and or strabismus, in addition to optic nerve signs of loss of vision, RAPD, ONH edema and atrophy, visual field defects, CRVO, and opticociliary shunt vessels. Whereas OPGs involving the chiasm present with bilateral visual field defects, usually bitemporal hemianopsia because they involve the decussating nasal fibers, seesaw nystagmus, a very important sign of chiasmal gliomas, obstructive hydrocephalus with ONH edema resulting from raised intracranial pressure, and precocious puberty because of involvement of the nearby hypothalamic pituitary axis. The optic chiasm is involved in almost half of all optic pathway gliomas. Optic pathway gliomas are also associated with neurofibromatosis type 1, and neurofibromatosis type 1 may have bilateral involvement of the optic nerve with optic pathway gliomas. Imaging of optic pathway gliomas shows thickening and variable contrast enhancement of both the optic nerve and its sheath. There is intrinsic enlargement of the nerve which may appear globular or fusiform. MRI is the preferred modality of imaging because CT scan may fail to differentiate it from other orbital tumors, and characteristically there is kinking or buckling of the nerve resulting from intrinsic enlargement of the nerve. There is enlargement of the optic foramen which may be due to intracranial extension or may be due solely to secondary meningeal hyperplasia. Unlike meningioma, there is no calcification or hyperostosis on CT scan. And OPGs associated with neurofibromatosis type 1 may show involvement of the arachnoid surrounding the optic nerve, resulting in double intensity tubular enlargement of the optic nerve in OPGs associated with neurofibromatosis type 1. Treatment of OPGs is controversial. Observation is instituted under most circumstances as most tumors are stable or only slowly progressive. So like meningiomas, they are slowly progressive. If there is evidence of progression, chiasmal invasion or severe visual loss, chemotherapy is initiated. Surgery is indicated in blind, disfigured proptotic eyes, or if there is evidence of extension towards chiasm and or the contralateral side. Radiotherapy is usually avoided in OPGs because of the younger age of these patients, but radiotherapy may have to be considered as adjuvant therapy to chemotherapy and surgery if there is post-treatment progression of chiasmal and post-chiasmal tumors. Radiotherapy may cause secondary neoplasms in neurofibromatosis type 1 and mental and growth retardation in young children. Optic pathway gliomas in many cases show early growth followed by long periods of stability, for which observation is adequate. If limited to the intraorbital optic nerve, though visual prognosis is poor, survival is excellent. But lesions involving the chiasm, third ventricle and the nearby hypothalamus reduce life expectancy. Malignant optic glioma of adulthood almost always occurs in adults with a mean age of presentation at 60 years, presents with rapid loss of vision with or without acute onset of periorbital pain. This rapid loss of vision with periorbital pain may make it difficult to differentiate initially from optic neuritis and non-arteritic AIOL. There may be ONH edema and atrophy, and second eye gets involved via the chiasm within a few weeks. Malignant optic glioma of adulthood originating in the chiasm, however, presents with bilateral visual loss. Imaging shows enlargement and enhancement of the affected portions with cystic degeneration. Treatment is usually ineffective and invariably blindness develops in a few months and death occurs within 12 months. Coming to infiltrative optic neuropathies. Infiltrative optic neuropathies can be due to inflammation, malignancy or infection. Leukemia, lymphoma, sarcoidosis, tuberculosis, syphilis and fungal infections are potential etiologies. However, metastasis to the optic nerve is rare. In infiltrative optic neuropathies, visual loss, either unilateral or bilateral, is often associated with pain, and the visual loss progresses more rapidly compared to compressive lesions. It usually affects retrobulbar optic nerve, causing late ONH pallor. However, if the process involves anterior optic nerve, there is ONH edema and ONH infiltration. ONH infiltration is more opaque than ONH edema and appears as a yellowish or greyish mass lesion which may be diffuse or focal and which may be associated with infiltration in the adjacent vitreous and or retina. Please look up on the internet for an image of ONH infiltration because I could not find a non-copyrighted image. The etiologies of infiltrative optic neuropathies may involve other cranial nerves also, and optic nerve involvement may precede or follow systemic symptoms of the causal diseases. In infiltrative optic neuropathies, imaging may reveal diffuse thickening and enhancement of the optic nerve sheath along with thickening and enhancement of the meninges of the adjacent skull base. It may be difficult to pick up in the initial image and repeat imaging may be required. Blood and serum analysis is often indicated and so is CSF analysis, which may need to be repeated. Thyroid eye disease is an infiltrative pathology wherein muscle enlargement and orbital fat hypertrophy can compress the optic nerve, usually at the orbital apex. The proptosis associated with thyroid eye disease may also stretch the optic nerve and cause its dysfunction. Though infiltrative, vision loss is insidious in onset, is bilateral but may be asymmetric and slowly progressive. Dyschromatopsia may be an early sign. ONH may be normal or mildly edematous early on. However, in long-standing cases, ONH atrophy ultimately develops. Treatment of thyroid eye disease-related compressive optic neuropathy includes systemic steroids and surgical decompression. Radiation therapy alone is not indicated in acute thyroid-related optic neuropathy, and radiation therapy is only reserved for cases not responding adequately to either systemic steroids or surgical decompression. Thank you for listening.